C5-6 Duke laser disc repair for a symptomatic herniated disc at C5-6. And you saw we did an endoscopic surgery, and we went in and, can you check the neck real quick and just make sure everything is nice and flat, no hematoma? Probably need to pull the collar off. Yeah, everything's good? All right, good. You know, sometimes we get blood pressure fluctuations. Okay, so we're going to be doing a carpal tunnel release. We've never broadcasted one of these. Maybe we did a few years ago, but I'm going to first exsanguinate the arm, and then we're going to put the tourniquet up, and then I'm going to take this elastic off. We'll cut open the bandage, which is sterile in there, right?
Yes, sir.
You've already prepped and draped it?
Yes, sir.
And then we'll be ready to do the surgery. So you have the tourniquet ready? Okay, so, all right. So, whatever you prefer. I don't normally manage the tourniquet, so whatever you want to do. I just usually let the anesthesiologist figure that out. And honestly, you can do this yourself, Luis, next time if you want.
Yes, sir.
So what we're doing is we're using an elastic to squeeze all the blood out of his arm. And this surgery is basically going to be a bloodless surgery. You'll see. And we have a tourniquet around his arm, which is going to inflate in a minute. Go ahead. And when he inflates it, it's going to stop the blood flowing to the arm. Now, obviously, you can't keep the arm without blood flow for very long. We're only going to have it for about 10 minutes max. So, tourniquet's up.
Good? Rita, we good? All right.
Sean, are you able to see the field?
We are watching from the eye in the sky right now.
Yeah, eye in the sky is fine. Perfect. All right, so the thing you want to be careful with here if you're a surgeon, don't cut the patient's finger off. I've not seen it happen, but it's happened before when I was in residency, not by me, but by another surgeon. I've heard stories about it. So the key to doing that is to not take big bites, okay? This scissor could easily cut a patient's finger off. So you want to get it just under the drape. You want to feel it. And then you want to take little cuts. And you won't cut any digits off if you do that, okay? If you're impatient and stupid, then you will cut something off. All right, so we've already marked out the incision. And so to keep the arm in the right position, we need some blue towels. We don't have any? All right, no, we're okay actually. All right, so I've already marked it out. The key here is you see the wrist crease right there, okay? The wrist crease is right here. You can see the wrist crease. You don't want to cut the wrist crease. You want to cut past the wrist crease. So I started about 1 centimeter past the wrist crease. And you can also see this little crease right here, this little wrinkle. If you look at, watch your finger, I got my needle next to you. If you look at this, the hypothenar eminence or the thenar eminence here, you want to be like basically in the middle. That's where the carpal tunnel is. I'm going to do an injection. Huh?
We have a seat.
Yeah, I'm not ready to sit down. So here we go, we're injecting. Now what I'm injecting is Marcaine with epi, right?
That's right.
And you're going to do sub-Q. You don't want to go too deep. Now some surgeons do this surgery endoscopically. I don't, and I'm an endoscopic surgeon. Why don't I? Because the failure rate of endoscopic surgery is so high because when you get in there, you think you're cutting the transverse carpal ligament, and you are, but you're not cutting the deep part. You only cut the superficial part. So the deep part is the part that actually pushes on the nerve. And I'll show you what I'm talking about when we get in there. The biggest failure of endoscopic carpal tunnel release is the fact that the surgeon doesn't cut the deep part of the transverse carpal ligament, and then the patient has to have a second surgery. All right, now we're going to make an incision, and then I'm going to use this retractor. This is the key retractor right here. This is the same retractor I use for everybody. And it's got blunt tips, and it's got this little crankshaft here, and you'll see we're going to put that in a minute, okay? So I don't really need to sit down right now. I'm going to, table's fine. So, no. I use a number 10 blade to cut the skin.
Can I have a blade, please?
And then I use a 15 blade to cut the transverse carpal ligament. All right. So we've already numbed up this area, and we've got our tourniquet up. We shouldn't have any problems. And then I don't use the Metzenbaum scissor, okay? It's been a while since I've done a carpal tunnel release. That's why we are making some adjustments. I use the 15 blade after I cut the skin. So it's 10 blade, and then it's retractor, and then it's 15 blade, and it's once I cut through the transverse carpal ligament, I can see the median nerve. Then I use the heavy scissors. All right, so we'll start with a 10 blade, and we're going to make our incision down. And by the way, this is the thickest skin in the body. Now you're going to see the fat. Okay, that's the yellow stuff. And again, you don't want to go to the crease. You want to stop short of the crease. Now what I do here is there's fat, and I like to use the back side of this, and I like to scrape the fat off of the transverse carpal ligament. I can feel the transverse carpal ligament. I'm putting my knife down, and now I'm going to get my retractor, and we're going to put it in, and it fits perfectly, okay? And we're coming down, and believe me, folks, I'm showing you this surgery for a reason, okay? I can't tell you how many times I've seen this carpal tunnel incision, like over here, and up the arm. I mean, it's crazy, some of the things people do, okay? So, let's suck that fat. See the yellow fat? Want to get as much of that out of the way as I can. Good, and let's see, I can just use the 10 for now. I don't like the fat there because it obscures the view of the transverse carpal ligament. Transverse carpal ligament is white. You see that down there? Yep, that's what I need. We'll take some of this fat out. We don't charge extra for removing fat. Plastic surgeons do, but we don't. All right, beautiful. There's the transverse carpal ligament. You see it? I need a 15 blade. So the problem is most surgeons cut through a little bit of this and they think they're done. Suck. Suck. Okay, like they'll stop right there. I'm done. No, you're not. And look at that. I need you to suck. Okay? I need the Penfield. Nope. Yeah, that's it. Watch your fingers. Help me rotate a little bit. Now look at that. That's a little bit of muscle. Again, they think they're done. They're not. You need to keep going until you actually see the median nerve. And see how there's that deep ligament right there? That's sitting right on the nerve. And yeah, he's got a very thick transverse carpal ligament. There's the nerve. You see it? Way down there. Can you see, Sean, right there? That's the nerve. And that's the problem, is that most surgeons don't recognize that. Now I need the little retractor over there. Let's see. What about the other one?
It's the same.
Same one? All right, let me have it. So I like to get this shoehorn, if I can get it in here. All right, that's too big. So I need something else. Let's see. Huh? Yeah, that's perfect. Let's have that. We're going to use my Woody, my favorite tool. Now I just got to get this in here, and you're going to feel, right there's the nerve. You're going to feel, and you got to get in there and just snip it. You don't snip the nerve, obviously. You want to snip, and there's a technique to it. He's got a lot of muscle there. You want to lift up, okay? There it is. You all see the nerve down there? Right there. You see the ligament right above it? I wish I had something a little wider than this. go. Apologize that it's so hard to see. But that's it. And then we'll go this way. I need the pen field. And we're going to go just above the nerve right there. You see that? And it doesn't feel like there's that much compression. This direction. Can you see? Let's move the hand a little bit this way. Let me see that. And let's rotate. There we go. See the nerve right there?
Yes, sir. Yes.
See, there's the muscle. And just deep to that is a nerve. And let's make sure it's decompressed. So I'm going to run this right above it. It feels pretty good. I don't feel any compression on the nerve anymore. Let's go the other way one more time. Let me have that, Woody. And there's the nerve once again, right there. You all see the glistening nerve? Right there, right there. All right, and so we're going to check just above it. And it feels good. I've got 90% of it. Yeah. That's really not bad right there. So we got it. We're done. Now notice how I always check to make sure. Now we'll sit down to close it. But that's the reason I need a chair here. Chair, please. Right here. That's the reason why there are so many failures of the surgery is the surgeons get lost. They have no clue just how deep that nerve really is. And so they cut the superficial layers of the transverse carpal ligament, the ones closest to the surface, and they think they're done. But they don't understand the anatomy. Whoa. No. What is this? No, we need a 0. All right, we'll try it with a 3. It's usually, it's usually a 2-0.
We have 2-0 as well, sir. You prefer a 2-0?
I prefer a 2-0.
Yes, sir. 2-0, please, Snyder.
Yeah. What does the card say?
The card says 9030.
No,
Yeah.
we never use a 3. 3 is not strong enough. So we're going to put a couple of stitches, and I'm going to use a vertical mattress suture. We need a bigger needle. I mean, that would work. I could make it work, but preferably a little bit longer needle if possible. Yeah, take that 3-0 off and put a 2-0. So I'm going to probably put about 3 stitches here. So you see how small the incision, folks, is? You never go up past the wrist crease. You always stay distal to the wrist crease. You never go down here. There's no reason. I see surgeons cutting down here. It's crazy. This is the least invasive open. That's perfect. Now I want a big bite on one side. I'm going to come across, okay, across, and then off the other side, okay. This is one of the best stitches that you can do in medicine right here. It's called the vertical mattress. Then I'm going to go back. I need to add some pickup. I need you to rotate the arm a little bit for me.
Yes, sir.
Rotate the hand and arm. I got to get my hand in here. All right, so you go wide, and then you go superficial to superficial. And what you're trying to do is evert the edges, but have a strong suture, strong stitch. Okay, it's beautiful. Look at that, how it everts the edges. The edges of the wound are everted, so they heal properly. Does that make sense? It's perfect. It's also easier to get the stitch cut at the end. You can cut the suture easier. Because what's going to happen is all this tissue is going to swell up in the next couple of days. We're going to take these stitches out in 2 weeks. By the time we take them out in 2 weeks, everything will be epithelialized. Go ahead and cut long. You want to do about 5 to 7 ties. Okay? So once again, I'll show you how I did this. Okay? We're going to start wide, really wide. And we're going to come deep in the fat. And then we're going to go out the other side wide. A little wider than that. Okay. How is this coming through, Sean?
Looking good.
First person view is nice.
A little bit blurry, but it's good.
Yeah. All right, then we go narrow, close to the edge. Okay, and we start narrow and come up narrow. See that? Isn't that beautiful? Yeah. Geez, it scares me, you know, with all the changes in healthcare, all these educational institutions going out of business. You know, they're all becoming basically bankrupt because the insurance companies are keeping all the money, and nobody's stopping them. They've neutered our politicians, our lawmakers. So teaching programs like Shands Hospital or Columbia University or Harvard, they're all struggling financially. How long are they going to be in business? You know? I think they're eventually going to go the way of the dodo bird. And so these videos that I'm training how to do surgery is going to be maybe all that's left. You know, fast forward 50 years. We never thought payphones would disappear, did we? No. Payphones. We never thought payphones would disappear, right? But now we have cell phones. So nobody saw that. We never thought SLR cameras would disappear, did we? Now we have all digital cameras. We never thought Kodak film would disappear. My wife and I were talking yesterday about in the old days when they used to do receipts, right? They would do a carbon copy. There's no such thing as carbon copy receipts anymore. Everything is digital. So I think surgical training is going to disappear. Why? Because insurance companies don't want patients to have surgery, and they seem to be ruling the world. So someday they're going to have no surgery training, and there won't be any doctors that know how to do surgery to fix people anymore. And that's going to make the insurance companies very happy. And they're going to continue to get what they want, as they have been, because nobody stands up to them besides me and a few other places, but very few. People won't figure out that they're bad for them. So all this educational institutions are going to disappear. Wet, dry. Don't do that right now. Wet, dry. Yeah, good. All right. We're going to do a wet, dry, quickly. We're going to put our bandages in here. I'll show you how to wrap a carpal tunnel release. Okay, I'll show you how to do it right. We have any polysporin or anything like that? Antibiotic cream? Do we? We need a little bit to put on there. Look how perfect that is. Look at the edges are all everted. And in 2 weeks, when this is all healed over, we're going to come and snip, pull, done. That's the right way to do it. No, just give it to me. Yeah. Okay. A little polysporin. All right, let's get the scissor. Get the scissor. And then you can start opening those. Give me the heavy scissor. You don't have a heavy scissor? I thought we had a heavy scissor. Yeah, the big guy. What do they call this scissor here? Mayo. Huh? That's not a Mayo. That's a Mayo.
Yeah.
This is called the trauma scissor or something, right?
Yes.
Yeah. All right. Huh? Yeah. Yeah, that's right. All right, so now we need the tweeners. Let's get all the tweeners. All right? So I'm going to do this. Watch. We're going to take these. We're going to wrap them around the base on each and every digit, okay? Because this patient's going to have an ACE bandage, and it's going to kind of squeeze the fingers together. And we don't want the fingers squeezed together all the way because that's uncomfortable for the patient. So we want to give them something in between the fingers. It's a cushion. So don't forget this. This is one of the more important steps. Okay. Did I do them all? Did I get this guy? I didn't get this guy. Any questions from our audience so far?
No questions.
That's wonderful. All right, now let's get a little more fluff here. You want to do, once you get the fingers done, you want to do a little fluff on the palm, a little bit of fluff, okay? A little more. Open these up for me. Open these up. Save me some time. Remember, time is of the essence. All right, so we fluffed up the palm. Perfect. And now we're ready to wrap the hand. And I'll show you. Do you know how to do this? Yeah. Lightly. Okay. Now, you don't want to, if you just do this like this, you'll squeeze all the fingers together. So you want to go around the thumb, and you want to not make it tight. Okay. You want to not make it tight. Keep it nice and loosey-goosey. Loosey-goosey. Okay. Otherwise, the patient will complain their fingers are all squeezed together. Okay, and they will be. We don't want that. We don't want their fingers all squeezed together. All right, otherwise they get really upset. They start calling your office. They call you at 3 o'clock in the morning. Not this patient, but this one doesn't complain. All right, done. Now, let's open this a little more so we can get the ACE bandage on. The last thing you're going to do, folks, is the ACE bandage, and then you're going to take down the tourniquet. Remember, the tourniquet's been on now for a while. Has it been 20 minutes? That's nonsense. Oh my God, you guys are lying to me. All right, I'm kidding. Of course they're not lying to me. My ego's been lying to me. Oop, he doesn't like that. All right, let's get this done with the ACE, and then we can take the tourniquet down. So, the ACE, again, if you do this too tight, your patients will complain. They'll get blue fingers, numb fingers. So it's just a light wrap. All right, and you want to be careful here. You're not squeezing those fingers together. Otherwise, it gets real uncomfortable for the patient. So it's just a light wrap. You want this on for about 3 days. You want the patient to elevate their hand, okay, at home on a pillow or something. All right, you can take the tourniquet down. Okay, we're done. So let's get the rest of this off. And let's wake this gentleman up. Okay, let's cut that. Let me have it. You have to be careful, especially people with wrinkles. So I slide in and I lift up. And by doing that, you pull it away from the skin. So the chance of hurting someone is almost zero. All right, so we just finished the right carpal tunnel release, open, but minimally invasive, Dr. Deukmedjian method, which is the best. I don't do endoscopic, even though I do endoscopic surgery. I don't do endoscopic carpal tunnel because it doesn't work. You miss the transverse carpal ligament, and then the patient doesn't get better. Notice how we cut down right on top of the median nerve in the canal, and we got the deep layers cut. We made sure of that. It was tricky. I thought we were deep enough, and then we got the muscle belly, a little bit of the muscle. You got to cut through that. And you keep going until you're sure you've got all the transverse carpal ligament. The other name for transverse carpal ligament is flexor retinaculum. Some people know it one way or the other. All right, I hope you enjoyed it, and I'll come answer questions. night, everyone. It is once again January 5th, 2021. This is our first surgery of the new year, and this happens to be my family member, my father-in-law. So he had a herniated disc at C5-6. He had compression of the spinal cord and nerve root, and anywhere else in the world he went, he would be offered a fusion, an ACDF, or an artificial disc. And a much better surgery than either of those by far is the minimally invasive endoscopic Duke laser disc repair, pioneered and developed right here at Duke Spine Institute. So he got lucky. His son-in-law is a neurosurgeon who pioneered a new technique in curing neck pain and arm symptoms by treating herniated discs without fusion, without open surgery, endoscopically. Now, I learned the basics of this surgery, the approach, the full endoscopic approach to anterior cervical disc herniation from a German spine surgeon and some Korean spine surgeons. Dr. Sang-Ho Lee, notably one of them, the pioneer in Korea, South Korea, of the Wuridal Hospital. And the doctors over there, they don't do anterior cervical endoscopic surgery anymore. Because they've had several complications, unlike us at Duke Spine where we've had 0 complications. The reason is that they do the surgery different than I do. I pioneered a new technique with doing things differently and safer for the patient and more reliable, more effective. One thing they did different was they had the patients awake during surgery, so they were moving. If your patient's moving and you're operating on top of the spinal cord, it's very easy to damage the spinal cord. It's just stupid. So I don't know why they did their surgeries that way, but they did, and that was wrong for them to do that. In my opinion, I would never do that. My patients are asleep, they're intubated, they're relaxed, completely relaxed with chemical paralytics, neuromuscular blockade, and they don't move, so there's no moving target, and so there's been no nerve damage or spinal cord damage to date. I've done over 1,200 of the surgeries. Now, our patient also happened to have carpal tunnel syndrome in his right hand, and he had numbness and tingling in his fingers at night. He'd wake up shaking his hand, bothered by it, so we decided to do a carpal tunnel release, and you could see the median nerve was being crushed by the transverse carpal ligament, aka flexor retinaculum. What happens in carpal tunnel syndrome is that flexor retinaculum gets thicker as the patient gets older, especially if you have diabetes or if you use your hands a lot. And that thickening of the ligament, flexor retinaculum, it actually crushes down on the nerve running underneath it, which is the median nerve. The median nerve has some motor branches that come off before the flexor retinaculum, proximal. So by staying distal to the wrist crease, you're effectively reducing the chance of damaging those branches, which is good. You don't want to, because they don't call it the $1 million nerve for no reason. The second part is the sensory fibers, which only bring sensation to the fingers, and that's really, once the motor branches come off and go to the thumb, the sensory branches go distal and they innervate the first 3 fingers, which is what causes all the numbness and tingling in those three fingers in the hand. So I was very careful to stay away from the motor branches, and you saw my technique. This was a more difficult one than normal. Usually they're a little bit easier because they're not so deep, but the surgery went perfectly, and you could see just how thick that flexor retinaculum is. And you see why a lot of surgeons screw the surgery up, because they don't know how thick the flexor retinaculum is. They're confused. They don't know where the nerve is. There's a lot of orthopedic surgeons that try to do carpal tunnel releases, and they don't know the nerves as well as a neurosurgeon does. So they'll get in there and they'll not do it properly. So, you know, one of the biggest truisms that we expound on quite often here at Duke Spine is the fact that all surgeons are not equal by any means, not even close, okay? They're about as equal as, Joe Namath is to a 4-year-old throwing a football. There's such a discrepancy and difference in the talent and in the accuracy and the precision and the results. It's literally a spread from the best to
to the worst. And people need to be aware of that. Too many people think all spine surgeons are the same and all spine surgeons surgery is the same. If fusion is a fusion. No, it's not. It's completely different. Even a carpal tunnel release is very different depending on how we do it. And unfortunately, at least 50% of the surgeons do it wrong. So if you just go pick a surgeon out there to do your carpal tunnel release, there's a 50-50 chance they're going to botch it up and do it wrong. Okay? And we're trying to educate the public about this fact so that you, the public, take your time, find the best that you can get to, and have the very best do your surgery and treatment. All right? Well, I hope you've enjoyed the broadcast. Do we have a question? Sean is going to read it for us.
One of our viewers is wondering, with this surgery, what is the maximum amount of time you can keep the tourniquet in place before it damages the blood vessels in the fingers?
Well, great question. So one of our viewers asked, how long can you keep that tourniquet up, restricting blood flow to the extremity before it causes damage, permanent damage? And that's a great question. So to answer that question, you have to know really what are the tissues in the arm that are sensitive to no blood flow. And the answer is all the tissues are sensitive to no blood flow. And then you have to ask yourself, okay, well, what's the most sensitive tissue in the arm to no blood flow? And that would obviously be nerves. And then there would be skeletal muscles and connective tissue and skin and then bones, right? So those are the main categories of tissues. So when you put the tourniquet up, you're stopping blood flow to all of those tissues, bone, nerves, muscle, and skin and connective tissue. You're stopping the blood flow to all of them, including the blood vessels. So all of those tissues are ischemic, meaning they're not getting enough blood flow. The question is, which one's going to die first? And the answer is the nerves. The nerves are always the ones that need the most oxygen, glucose, and they need to eliminate their carbon dioxide waste because they're highly metabolically active and they're very sensitive. So the answer to that question is really nobody knows for sure how long you can keep the tourniquet up, but you really don't want a tourniquet up for any longer than about 30 minutes. We were at 20 minutes, and that was it, right? 30 minutes should be fine. When you get to an hour, then you're going to have some problems. You may develop what's called a compartment syndrome afterwards, which is really bad. That's where you have damage to the muscles and tissues that causes swelling, and the swelling in your forearm is restricted by compartments, which are connective tissue, basically compartments of tissues inside a thick connective tissue band. And when that happens, and you get swelling of tissues, you can get permanent damage. So the surgeon has to go in and do a release where they cut the fascia open with a scalpel and make long cuts along your arm. It is very rare for that to happen. I've never seen it happen as a result of this kind of surgery, but it could happen. So to avoid compartment syndrome and avoid nerve damage, you want to restrict your tourniquet time to less than an hour, okay? And typically you want to shoot for less than 30 minutes. Any other questions? Thanks for watching. That's the last surgery for today, January 5th, 2021, the first surgery of the year. And we're going to be back on Thursday morning with two big surgeries for the day. The first is a 4-level L23, 34, 45, 51 decompression, derotation, and instrumented fusion with inner body cages at L23, 34, 45, 51, inner body fusion, L23, 34, 45, 51, posterior fusion, L23, 34, 45, 51, segmental fixation with pedicle screws, rods, cross links, L23, 34, 45, 51, and osteotomies, Smith-Peterson osteotomies, removing these abnormal facets that this patient has. Her spine is locked in a twisted configuration. We're going to remove these abnormal joints that are locking it in, and we're going to free up the spine, and then we're going to derotate it or untwist it, and we're going to fuse it. And we're also going to decompress the nerve roots that are being pinched. So this is, kind of surgery that done anywhere else in the world. Besides Duke Spine Institute, the patient would be in the hospital for 2 weeks. They'd probably have a 25% chance of complications, like pneumonia, blood clots, pulmonary embolism, all kinds of weird complications, infection. But we're going to do the surgery outpatient. Our patient will go home 2 hours after surgery, and we have the best anesthesiologist in the world here, Dr. Santiago, doing the case with me. He's done many of these surgeries here at Duke Spine Institute with me. We've been doing outpatient multi-level fusions and osteotomies now for 7 years. We've had 0 complications here at the facility as a result of the surgery. So we have literally the lowest complication rate in the world for complex spine surgery. And we've been doing them outpatient for 7 years. No one else in the world does these surgeries outpatient like we do. And we're very, very advanced in our technique and our outcomes. So we just want the world to see what the very best can be done, so you guys can weigh and measure and compare to what is being offered to you where you are. Again, most spine surgeons that do this surgery, it's going to take us 4 hours. Most spine surgeons would take 18 to 20 hours to do this kind of surgery. But we're going to get it done in 4 hours because we're very accustomed to doing these techniques. I've done it hundreds and hundreds of times over the years. And we do it exactly successfully. We know exactly how to manage and prevent complications. So should be a good surgery. It'll be wide open. Bring a couple of bags of popcorn and, schedule the morning off so you can watch. All right, we'll see you on Thursday, and then we'll be doing a 3-level AC.